This is Stephanie Huff, and I'm recording another concept of acid-base balance. This one is for metabolic alkalosis. Metabolic alkalosis is characterized by a high pH greater than 7.5, high carbonate, which is greater than 28. This can be caused by a loss of acids or excess bicarbonate in the body. The respiratory system attempts to compensate by slowing the respiratory rate. Carbon dioxide is retained and PaCO2 levels increase to greater than 45 millimeters per mercury. Pathophysiology and etiology: hydrogen ions are lost through the kidneys or via gastric secretions, or because of a shift of hydrogen ions into the cells. Metabolic alkalosis is due to loss of hydrogen ions, usually from vomiting, gastric suctioning. Gastric secretions are usually highly acidic, so when they're lost, alkalinity of the body increases in these bodily fluids. This increased alkalinity results from loss of acids and selective retention of bicarbonate by the kidneys. As chloride is depleted, chloride is the major anion in extracellular fluid, so when it's lost, bicarbonate is retained as a replacement ion or anion. Increased renal excretion of hydrogen ions promoted by hypokalemia as the kidneys try to compensate. Excessive bicarbonate could be from ingesting acids or overtreatment of antacids or overtreatment of metabolic acidosis. Risk factors: it rarely occurs as a primary disorder. Risk factors include hospitalization, hypokalemia, treatment with bicarbonate. Manifestations result of decreased calcium ionization and are similar to that of hypocalcemia. So they may have numbness, tingling around the mouth, fingers, and toes, dizziness, positive Trousseau's and Cheboks's sign, muscle spasms, as the respiratory system compensates. Respirations are depressed, and respiratory failure with hypoxemia and respiratory acidosis may develop. Collaboration: metabolic alkalosis typically is caused by an underlying primary disorder. Plan of care and therapeutic regimen are aimed at controlling alkalosis while treating the underlying cause. Pharmacologic therapy: treatment includes restoring normal fluid volume and administering potassium chloride solutions. Potassium restores the serum and intracellular potassium levels, allowing the kidneys to conserve hydrogen ions more effectively. Administering sodium chloride solution, the chloride promotes renal excretion of bicarbonate. In severe alkalosis, administering acidifying solutions like a dilute hydrochloric acid or ammonia chloride. Drugs may also be used to treat the underlying cause of alkalosis. Looking at lab and diagnostic tests, ABGs are going to show a pH greater than 7.5 and a bicarb level of greater than 28. Serum electrolytes: you will see a decreased serum potassium, less than 3.5, decreased chloride, less than 95. Urine pH may be low. EKG patterns show changes similar to those seen with hypokalemia. Nursing process: you want to teach risk of using sodium bicarbonate as an antacid to relieve heartburn or gastric distress. Stress the availability of other antacid preparations and the need to seek medical evaluation for persistent gastric symptoms. Looking at the health history assessment, need to look at current manifestations such as numbness, tingling, muscle spasms and dizziness, the duration of their symptoms, any precipitating factors, could be bicarbonate ingestion, vomiting, diuretic therapy, and endocrine disorders, also their current medications they're on. Physical assessment is going to include vital signs, apical pulse rate, depth of respirations, muscle strength, deep tendon reflexes. Diagnostic tests are going to include ABGs and serum electrolytes. These are your NANDA diagnosis. Planning depends on identifying and treating the underlying disorder. Outcomes can include restoring and maintaining normal acid-base balance, returning to an oxygen saturation of greater than or equal to 93%, and a return to normal or near normal fluid and electrolyte volumes. Implementation, nursing interventions, we're going to focus on controlling the pH while treating the underlying cause and preventing complications. Monitoring for impaired gas exchange. The respiratory compensation for metabolic alkalosis depresses the respiratory rate and reduces the depth of respirations to promote CO2 retention. So you want to monitor respiratory rate, depth, and effort. Monitor their oxygen saturation continuously and report any levels that are less than 93. Assessing the skin color, you want to note and report cyanosis around the mouth because that indicates central cyanosis, which is a late sign of hypoxia. You want to monitor mental status and level of consciousness. You want to report any decreases in level of consciousness such as restlessness, agitation, confusion. Any changes in level of consciousness can be an early sign of hypoxia. You want to place them in a semi-Fowler's or Fowler's position as tolerated. Raising the head of the bed will facilitate alveolar ventilation and gas exchange. Administer oxygen as ordered. Scheduled nursing care activities to allow frequent rest periods. That also helps conserve their oxygen. Monitoring for fluid and volume deficit. You want to assess intake and output accurately. The urine output should be at least 30 milliliters per hour. This indicates adequate renal perfusion. Anything less means the kidneys are not being adequately perfused. Assess vital signs, CVP, and peripheral pulses for their volume at least every 4 hours for signs of hypovolemia. Decreased blood pressure, decreased CVP, tachycardia, and weak peripheral pulses indicate hypovolemia. You want to weigh the patient daily under the standard conditions that we've talked about continuously. Administer IV fluids as prescribed. Monitor serum electrolytes, osmolality, and ABG. All right, looking at care in the community, you want to consider the cause of alkalosis and underlying factors. Teach about using appropriate antacids, using potassium supplements as ordered. This includes eating high potassium foods to prevent low potassium when taking potassium-wasting diuretics. Contacting the primary care provider if uncontrolled or extended vomiting develops. Evaluation. Normal outcomes of nursing care related to restoration of normal body balance. Your possible outcomes will include client reports use of antacids that are acceptable for use that will reduce recurrence of metabolic alkalosis. Client describing proper self-administration procedure for oral potassium supplements. Them describing when to notify the healthcare provider. Their understanding of pH returning to normal range and the serum electrolyte values being within normal range. This is the end of metabolic alkalosis, and as always, if you have questions, let me know.